Hi, everyone. Good evening. Welcome to our virtual open house here at the Children's Hospital of Richmond and VCU Health. For those of you who don't know me, I'm Nick Johnson, Vice Chair of Research in the Department of Neurology and Director of our Muscular Dystrophy Translational Research Program here at VCU Health and the Children's Hospital of Richmond at VCU. I want to first take a moment to thank you for joining our virtual open house. This is, we're doing this today because this is the first annual International Myotonic Dystrophy Awareness Day, and I'm just super excited. First of all, I want to say a special appreciation to Senator Tim Kaine, who introduced the first ever U.S. Senate resolution designating today as an International Myotonic Dystrophy Awareness Day. We in the Commonwealth of Virginia are fortunate to have such a strong advocate in Senator Kaine, and we really do appreciate his efforts to raise awareness of this rare, multi-systemic, progressive inherited disease that really affects an entire family. For those of you who have been on social media, you can see that this is a pretty exciting day, and there are events going on throughout the country, and at least on social media, focusing our efforts on this important condition. We're fortunate here in at VCU to be leading the charge in developing treatments, understanding the disease itself as myotonic dystrophy and congenital myotonic dystrophy. And I do want to share some of the panelists that we have here that are our team of experts here within our program dedicated to the research. And we're going to talk through some of the clinical research we're doing and some of the look at the new discoveries that are happening in our lab. We do have a few of our program team members who are going to share their vision and updates. So Melissa Hale is a postdoctoral fellow in our program, Jessica St. Romain, who's our clinical research program manager, and Jody Howe, who's one of our clinical research coordinators. And each of these speakers will be providing an overview of their focus and their work in the field of myotonic dystrophy. We are going to have time at the end to answer questions that were submitted in advance of our event today. If you didn't get a chance to submit a question, you can use the Ask a Question chat feature in the Zoom toolbar at the bottom of your screen, and we will certainly be happy to answer that question then. So I'm hopeful that next year and on this day, for the International Myotonic Dystrophy Awareness Day, we can meet in person, but since we can't, we're going to take you to the lab virtually. Before we can begin with updates with our team, we're going to present a short video that provides you an insider look at the work that's happening here. So it will make you feel like you're basically at VCU and the Children's Hospital with our work. And if you're okay, Leah, you can go ahead and start that video.
The home of the Muscular Dystrophy Translational Research Program, and what you can see around me is our lab space where a lot of the direct sequencing occurs, as well as the cell culture that we need to do to really help patients with muscular dystrophy. Our program is dedicated to advancing therapeutics for patients with those incurable genetic diseases such as the muscular dystrophies. And the way I think about those conditions is that there's a whole group of individuals that have problems with their DNA that affect their muscles, that affects their ability to breathe, affects their heart muscles, affects their ability to walk and generally live their life. Our clinical program is a multidisciplinary clinic that is supported by the Muscular Dystrophy Association. That allows us to bring all of the necessary team members into that clinic together, from myself and Dr. Harper to speech therapists, physical therapists, genetic counseling, and essentially any other person. It's really a one-stop shop for patients with these conditions.
Our current team has about 6 to 7 providers. We have an endocrinologist, we have a physiatrist or rehab doctor, we have an orthopedist, we have a cardiologist, a pulmonologist, a neurologist, and sometimes also rely on other providers such as a gastroenterologist. So it's not just one person providing the care, it's really a whole circle of people kind of surrounding that child and giving them the best care possible. And this is truly why our neuromuscular clinic is a clinic of excellence and is representing more of the region at this point.
We leverage that clinical environment to do research, to understand quantitatively what is it that makes the disease worse? How quickly does it progress? Are there things that we can be doing, like exercise or not exercising, that can really help patients understand their condition?
As a postdoctoral fellow here in the group, I am responsible for directing and managing a lot of the molecular research work that we conduct as a team.
I'm our group's computational biologist, and so what that means is I deal with essentially everything data related to the many different projects that we're working on.
We are in an incredibly privileged position in that Dr. Harper and Dr. Johnson, as they treat their patients, do so across the street from us. And what that means is that our clinical research coordinators and our team bring back samples from these patients, whether that's blood, muscle biopsies, urine, all incredibly valuable biological samples that are going to help us as a team. And they come back and they walk across the street here. They're processed right here next door.
We can go ahead and process that and actually get genomic data that then I can analyze and look for anything related to their diseases and try and gain a better insight into their disease.
And any information that we're capturing from those patients at the bench, we're talking about it to Dr. Johnson on the other side.
Our secret sauce actually in the program is the collaborative environments. Even though we're not looking at it right now, we're looking at the bench. Really up and down the hall, we have team members that work in the clinic and in the lab and in clinical research. And they all sit together, we all talk together. And one of the best things that happens out of that environment is that we're able to really translate those discoveries as efficiently as possible. We're just seeing an incredible, tremendous growth of new therapies, lots of promise for many of these conditions in the next 5 years. And frankly, one of the things that's hardest for us is trying to keep up with the pace. And that's why I think we're always interested in additional community support and partnerships that help us drive progress forward.
We've seen the strides in our whole community make active efforts towards their treatment. And that is something that keeps me coming back. Because me sitting down at my bench every day to just pipette a couple of things can make all the difference moving forward.
I'm very passionate about my care for these children. Everyone knows that I often refer to them as my kids, even though that they might not be. But to be able to offer these therapies and these supports for the first time, and to also give each child that opportunity for research, this is exactly where I want to be.
Without the ability to really, literally take it from bench to bedside and back to bench, we think that progress would be substantially slower. And that's the reason why we built the program in such a specific way, why it really does cover a wide array of different research and different opportunities, and has such a diverse membership of staff that help us drive that progress. Because my hope and my goal, and one that I share with many patients and families that I speak with, is that in the next 5 years, we're going to have some sort of genetic or disease-modifying therapy for many of these patients. Where there wasn't anything before, we're going to be at least able to enroll them in a clinical trial to test these therapies, and ideally, even better, prescribe it right in clinic and put myself out of a job.
Thanks, Leah. And as I said previously, hopefully next year we can actually do this in the lab. We have space here where you can just see everything for yourself. Since you can't do that because of COVID restrictions, and maybe because some of you are coming from out of town, many of you have seen our clinic, but you may not have seen the lab where we're doing behind the scenes work. And I think one of the things that we focus on very much, and it's a successful part of of our program and development here is keeping the lab and the clinic as closely aligned as possible. So with that, you can see our team is committed to providing patients and families with the latest treatments and clinical trials. I'm going to turn it over to Jessica St. Romain and Jody Howell. Can you tell us a little about the upcoming clinical studies that people might be able to participate in? Lots of exciting stuff going on here.
Yes, thank you, Dr. Johnson. As you mentioned, my name is Jessica St. Romain, and I manage the clinical operations team in our muscular dystrophy program. As mentioned earlier and in the video, one interesting and unique point about our program is that we are truly translational. So our clinical operations team is literally right next door to our lab. And you'll hear a little bit more from our lab manager, Melissa, in a bit. But while they focus on advancing therapeutic development and better understanding the genetic causes of myotonic dystrophy, our clinical operation team focuses on the data collection, functional assessments, and the clinical progression of the disease. Our wonderful group of clinical research coordinators and research assistants work directly with patients and their families to navigate them through the clinical research process. Another part of the service that we provide that hasn't been mentioned yet tonight is that we actually manage a large clinical research network. This network is called the DMCRN, and it's a network of 16 clinical sites all over the world who are focused on enrolling DM patients into these trials. So it's a very exciting time for us in DM research as we do have some of the first treatment trials beginning now. We've actually just in the last couple of weeks dosed our first child on a trial. And we also still have a series of trials dedicated to understanding the natural disease progression. So our natural history trials are still available. And these also help to better understand the clinical outcomes and the best assessments to define them. So I will actually now turn it over to our lead DM coordinator, Jody Howell. She can give a rundown of the actual study opportunities that we have currently available or upcoming soon. Jody.
Hi, everyone. Thank you, Jessica and Dr. Johnson. I'm going to share my screen. I'm going to list the current DM studies we have available here at VCU. Okay, the current studies that we have are DM1, TREAT, CDM, STOP, DM2, REACH, CDM, and upcoming ones are Avidity and Aspire. DM1 is a natural history study for subjects with myotonic dystrophy type 1. This study is to study the disease progression in large numbers. It's 24-month study with 4 visits to site. We're enrolling 700 adults between the ages of 18 and 70 years old, and we're doing functional measures and speech measures. The next one is TREAT, CDM. This is also a natural history study for patients with congenital myotonic dystrophy to study symptoms of CDM and the urgent need for clinical trial readiness. This trial is a 24-month study with 4 visits spread over a 2-day period. We're enrolling 100 children from the ages of 0 months to 15 years of age. We're taking functional measures, speech and feeding measures, and cognitive function measures. We are also doing a STOP DM2. This is also a natural history study for patients with myotonic dystrophy type 2 to study the progression of the disease. This is a 30-month study with 4 visits to the site, enrolling 50 adults between the ages of 18 and 70 years old. We're taking functional measure assessments. We're doing a DEXA scan, which is a muscle density, and we are also doing an EMG. The next study is REACH, CDM. This is actually a drug therapy study. This is a randomized double-blinded study to evaluate the efficacy and safety of glizumab. Glizitazumab versus placebo for children and adults with adolescents with congenital myotonic dystrophy. It's a 20-week study with 12 visits on site, enrolling 56 children ages 6 to 16 years old. It's an oral medication taken once daily. We're also collecting functional measures, cognitive functional measures, and a DEXA scan. It also has an optional sub-study for muscle biopsy. And then after the study ends, you have the option for open label extension study. The next study is Mirena. This is going to be coming in the fall of 2021. This will be a therapy study as well. And it is a phase 1 study to evaluate the safety and tolerance and the pharmacokinetics and the pharmacodynamics of a singular or multiple dose of study drug administered intravenously to adults with myotonic dystrophy type 1. It has 2 parts. It has a part A, and it is 7.5 months. And there's a part B that is going to be 7.5 months long too. We're enrolling 44 adults between the ages of 18 to 65 years old. This includes muscle biopsies, PK sample collections, EKGs, and an echocardiogram. And it also may have the possibility of open label extension study to follow after the study. And the last study that is coming this fall is Aspire. This study is to establish valid and reliable clinical endpoint assessments for children with genital myotonic dystrophy and childhood onset of myotonic dystrophy. It's an 18-month study with 4 visits on site, enrolling 30 children from ages 0 to 16 years old. We're taking function measures, biomarkers, muscle biopsies, DEXA scans, and blood samples. This will be conducted at BCU. And those are the studies that we have currently going. So now I'm going to pass it over to Melissa or Dr. Johnson.
Yeah, I think if you stop sharing your screen, you're good there, Jody, because we can, just as a reminder, if you join later, so you can type your question in the Q&A portion if you have any questions. You know, I think one of the things that's worth mentioning here, so you can see, you know, here we are on the first ever DM Awareness Day, and we're really just at the point now where we're starting to begin treatment trials that might have the potential to change the course of the disease. So hopefully by second DM Awareness Day next year, we'll have fewer of our natural history studies and more of our treatment trials. That's always my goal. But I do think that there's a lot of opportunity in those natural history studies. For those of you who have participated, for example, in NDM1, you will notice if you're participating in later studies like the Avidity Mirena study, that the design of that study, the tools that are used is directly related to what you did in the NDM1 study. So it really is quite informative. Likewise, for those of you who have participated in either Help CDM or Treat CDM, you'll notice that the AMO clinical trial is heavily based off of the work that we did in those particular studies. And for the new Aspire DM1 CDM study, that study came out of work that was, the blood and muscle samples that were obtained as part of the Treat CDM study. And as Dr. Hale, when she comes and talks in a second, we'll know, we'll be able to talk about as we get going here. The reason why we're doing that study is because we identified changes in the muscle that required and really focused us in that younger population in children with congenital myotonic dystrophy. So a couple questions here that I'm going to answer, and maybe Jody will help me out here. So one question is there any way to have a capsule for medication in REACH CDM? Jody, no capsules, right? It's just a sachet. And maybe there's a rumor that maybe it doesn't taste as good as some people would like. Is that what I've heard so far? So
That is correct. It is strawberry flavored, and it is mixed in liquid. It's a sachet, and it's mixed in 100 milliliters of water.
The reason why it's in a sachet is because it's not uncommon that drug developers, when they're developing oral therapy, haven't gone all the way to capsulation if they're not sure the medicine's going to work. And so typically the development of capsules comes awfully late in the study. For this particular medicine, there are issues with the absorption. If you've ever taken like an antibiotic where they told you you need to not eat 30 minutes later or an hour or whatever it is, it's because they're having trouble getting the drug absorbed orally. And that's been true, or the issue for this particular Ticluzumab as well. And so that's the reason why it's a sachet, and it's specifically in the liquid. It is unfortunate, and I know that the kind of fasting periods around it are somewhat challenging. Another question: if you do reach DM, are you eligible for RENA at the age of 18? Well, that's a great question. While we can't say a lot of details about the MARINA study right now, one thing that I will say is that it will be, you will need to be an adult, and you may not have congenital onset, so that won't include you in that particular study. I do know that company, as well as a number of other companies that are in the same space, such as Avidity, are working hard on getting that the medicine that they're testing in the MARINA study to be tested in children with congenital myotonic dystrophy. Everyone knows that that if you're going to approve a therapy for myotonic dystrophy, it can't just be in adults; it has to be for kids and adults. And the way that most people think about doing that is because it's because of FDA guidance. If they can do, they're supposed to test the therapy the first time in adults. And so that's why you'll see the MARINA studies initially in adults. It focuses a lot on safety. As we get through the first part of that study, my expectation is you're going to hear more stuff about how what that trial will look like in congenital myotonic dystrophy, or in children with myotonic dystrophy, as well as other studies coming for children with congenital myotonic dystrophy. Your participation in any one of these studies is your choice, or if you're the adult, it's your choice for your child. Every time we get something new, or we have something new coming down the pipe, you will hear from myself, Jessica, Jody, and the rest of our DM coordinators about what the pluses and cons are of that particular study, and whether or not you should switch. So I think that covers that primarily. And then Jody, one last question about the REACH CDM, the fasting procedures. Can you remind us of what that looks like?
The fasting is 4 hours beforehand, then you dose, and then 2 hours after. So with the current subjects that I have, one patient is taking it in the morning time, and the other one is opting for the evening. The morning time, the parent wakes the child up when they get up for work, doses, lets them go back to sleep, and then they get up for work. And then by that time they get them ready for school, that 2 hour time frame has passed. The other one is going to do the evening dose at bedtime, wake them up 4 hours into sleep, dose, and then let them go back to sleep.
Great. And then one last question. I'm going to turn it over to Dr. Hale. Is there any site or place where we would register to be eligible for trials? If you are here with us today, we know you, and we are thinking about you. And certainly if you have been participating in our natural history studies, we really do know you. And our obligation is that you've done your part. You've helped us collect the data, understand the disease progression, understand how to measure change in the disease. And our obligation, like I said, is if you're eligible for a trial, we're going to let you know. and work with you on that. And then one more question came in. I'm going to turn it over to Dr. Hale. Jessica, the question is for you. How soon will the Aspire Novartis trial begin? This might be, okay, we'll give her a minute to come off mute.
Sorry, there was a bit of a delay. We hope to be doing all of our internal training on the Aspire trial towards the end of October. And so we would expect late fall for enrollment to actually open.
All right, so you've heard a lot about the clinical program, and I said, the reason why we built the program the way it is the translation between our lab and our clinic, and we think that that's what really helps accelerate drug development in myotonic dystrophy, which we need to do so quickly. Dr. Hill, do you want to talk a little bit about what's going on in the lab?
Certainly, Nick, thanks for the intro. I am going to briefly share my screen as well to get everyone here a bit of an update on what our lab team has been up to. So my name is Dr. Hale. I'm a postdoctoral fellow here in Dr. Johnson's laboratory, and my responsibility as part of our DM team is to help sort of drive the molecular experimentation that we're doing based on some of the samples that patients are providing to us to try and get a better capture of what's happening in both patients with myotonic dystrophy and congenital myotonic dystrophy. As a just brief intro, what do we do here is a really important question. And I like to think of the goals of my molecular team is to understand the molecular changes that occur in DM and CDM patients that are causative disease. And that breaks down into a lot of different questions that we think about. Specifically, what are the molecular mechanisms that are responsible for the changes that are causative of disease? Can we develop targeted therapies to restore these perturbed processes? And how do we define when our therapies are effective? One of the ways that we do that, and that our team has been really driving forward as a consequence of the amazing donations that individuals have provided as part of the specifically HELP DM1 and DM1 HELP CDM and Treat CDM studies, is we are performing whole transcriptome sequencing of both CDM and DM1 patient muscle samples provided as biopsies in these studies. In particular, what is amazing about the set of data that I'm going to share a little snippet of to you today is that we have 35 patients with congenital myotonic dystrophy, which is in fact the largest cohort of CDM patients to date. We also have been working with collaborators. We have 21 pediatric unaffected controls, 7 adult unaffected, and 22 adult onset myotonic dystrophy patients. What we do from this muscle biopsy is we extract RNA from these particular samples, and we use a machine from Illumina called our NextSeq 550 to get a full picture of what's happening in that muscle RNA transcriptome at any given moment, or in that moment in time. And this analysis, as I mentioned, is the largest to date in the world. And in fact, we are one of the, what makes me really excited about our group in particular, not only because of our clinical collaboration, is that we are one of the few groups in the world that think specifically about congenital myotonic dystrophy. One of the primary things that we have learned, what I'm showing you here is basically an aggregate snapshot of how these particular transcriptome profiles that we've generated in the lab from our patient muscle look like at any given moment. And they're color coordinated by who they are. So our adult DM1 patients are in purple. They're generally right here, if you can see my cursor. Our CDM children are in blue, and our controls tend to hover over here. The closer you are together on this map, the more similar you are. And what this really is showing me is that our adults and our pediatric control patients really like to hover together. That's what we would expect, given that these patients are unaffected with a muscular dystrophy. But what was really surprising to us is the range of heterogeneity of our CDM patients specifically. Traditionally in the myotonic dystrophy field, at the molecular level at least, we often think of CDM children as having the most severe version of this disorder. And the fact that these children are spread across this map really suggests that that's maybe not quite true. In fact, when we start to dig deeper, we find that there are some select CDM patients that appear to be in a range of about 2 to 10 years old that have this very interesting profile. What I'm showing you right here is a color-coded, I think of it, it's called a heat map, but I like to think of it as simply a color-coordinated shot of the transcriptome at any moment. And what I'm showing here in this box is where our unaffected individuals, whether they're pediatric or adult, sit, where all of these particular colors are representative of what their transcriptome looks like at any moment. And this is the normal color pattern that we would expect if as an unaffected individual. Unsurprisingly, we have a large group of CDM and DM1 patients that show a reversal in this snapshot, which is representative of many of the type of things that are happening in the muscle that are causative of the patient symptoms that are experienced. But what was probably the most surprising and what we're actively exploring right now is trying to understand this subset of individuals that we've identified in our study that look a lot like our controls. They were born with CDM, and currently at this particular moment in their development, their transcriptome doesn't suggest that they're suffering potentially from the same molecular changes that we would expect for the patients with disease. That's what we're thinking about right now. And this is hot off the press data that we're working really hard to try and understand and to leverage for potential therapeutic advancement. I want to end this just brief sort of snapshot in that the patients and their families are really at the core of what we do here in the laboratory space. Much of the research that we do here would not be possible without the generous donations of both blood or tissue samples, but as well as the functional measures that are being collected in the clinic. Because our goal at the end of the day is to be able to take all of this back to you to learn, to define what's happening in the disease, maybe some modifiers of disease and potential therapeutics.
Thanks, Melissa, and certainly happy to take questions about what's happening in the lab, but maybe I'll start with a question here, which is, that unaffected group, are there anything that you noticed right off the bat from looking at different ages of the samples?
Thanks, Nick. That's a great question. That was something that we did notice right off the bat, which was really interesting. We saw a very clear pattern where children under the age of 2 at time that our muscle biopsy was collected generally had a transcriptomic profile that suggests that they do in fact have a very severe form of DM. But the children in that particular box that I outlined that didn't necessarily look like that were around the age of 2 to 10, which is particularly interesting because that's a period of time that we've learned from our clinical trials, specifically our natural history studies, that patients are maybe experiencing maybe a different type of symptomatic onset, but don't necessarily have as many muscle phenotypes as we might expect. Maybe Nick, you can comment on this a little too.
Yeah, I mean, I think it doesn't, I think it's important to remember that a couple points from these data. One is that it's cross-sectional. So in very rare cases, have we been able to have a muscle biopsy come from the same person over time. And so you're comparing 2 people to each other. And so there's always a little bit of a danger in doing that. For those of you who participate in the studies, I'm sure you would agree that you would rather have us do that than have us take repeated muscle biopsies where possible. So I certainly understand that. And then the last thing that I'll make a point is that this is very specific to the muscle changes that we see. It doesn't, this is just the thing that we see in the muscle and myotonic dystrophy. It doesn't speak to necessarily what's happening in the brain or the gut or other organ tissues. And so that's worth mentioning. But it is an interesting observation and parallels what many of you have heard me say in the clinic is that we see, especially in children with congenital myotonic dystrophy, that the symptoms are quite severe early on in childhood. And then they do seem to improve, at least the muscle symptoms seem to improve. And so it's not surprising that their splicing profile would improve at the same time. Maybe one additional question that I'll answer is that, how does this affect how we think about treatments for these children? And the thing that I'll say is that much of our work in developing treatments for myotonic dystrophy has to do with knocking down the repeat to allow for RNA splicing to change. And so I think you can take a couple of points from these data. Is number one, we do see the same RNA splicing changes in children with myotonic dystrophy as we would see in adults, and that information is something that we know here at VCU and have been sharing with our colleagues in the pharmaceutical industry. It's an important point because one of the first questions that I sometimes get asked is, well, is it the same disease, with the same type of treatment help children with myotonic dystrophy? And the short answer, based on the data that Dr. Hale shows you, is yes. And then the second part of that is, thinking about these splicing changes, it may suggest the ages at which we would want to start to introduce treatments to children with myotonic dystrophy to be able to have the most benefit for them. So we're definitely using the RNA splicing data that you saw there, as well as the clinical outcome measures to design those upcoming treatment trials in children with myotonic dystrophy, and that's root cause. And then also one last point, I'll stop talking for additional questions here, which is that the Aspire DEM study, which focuses on understanding the disease progression early on in childhood, is largely rooted off that the RNA splicing changes that we see most significantly in early childhood. We think that is potentially an ideal window that's an ideal window for people to potentially receive treatment with myotonic dystrophy, but we need to prove that with a larger group. Our sample size is not large enough to fully validate that. So, okay, so I'll stop talking there for a second. Maybe Melissa, Jessica, and Jody, if you can come back on camera, and we'll allow for some additional question and answer here. One question, Jody, can you email your PowerPoint presentation? Maybe I'm going to defer to, I'm sure we can. I don't know how, I guess, Jody, do you want to email that, or I'll email that to people around on the webinar today?
Sure. Yes, we can email it.
I'm sure we can. All right, so that was one question there. Dr. Hale, any thoughts about, one of the things that we are interested in our group is that because we see both adults and children, sometimes we see families where we see these large repeats jump between generations. Are we working on that at all?
We definitely are. That is actually another active area of effort that is being currently now worked on by a couple of our team members. We're actively actually using genomic DNA provided by patients, often from a blood sample collected by people like Jody at the clinic. We're taking that back and we're performing another type of analysis where we're trying to assess our DNA and see if there's maybe any other things happening in a genetic context that could explain some rapid expansion, as we sometimes like to call it, or not rapid expansion in select families. In fact, we actually have a couple of hits that we're exploring right now where we're validating them in our systems, our cell culture models, and our in vitro models at the bench to try and figure out what's going on. And then ideally, if we can learn what's happening, leverage those for therapies.
Great. I'm glad to hear that we're working on that as well. And then Jessica, maybe a question for you. One of the unique features of our program, and one of the things we're trying to represent here, is that we sit at the hub of a large network. So, let's say people here have family members that maybe can't come to Richmond or want to go to another site. How do we get them to the closest clinical site that has these treatment trials? Although I would argue that Richmond has maybe the best food, and it is a very pleasant place to stay. Jessica, how would you get people to someplace closer?
Absolutely. So we, as Dr. Johnson mentioned, we are the centralized hub for the Clinical Research Network. So it would just be reaching out to myself or to Jody as the lead coordinator, and we will then work with the patient and the family to get them matched to the site that has spots available for them. and get you enrolled. And we'd be happy to facilitate that.
Great. I think one other question or comment. So we're going to email Jody's presentation as well as a link to the recording, because that was another question that people asked. So, all right. And one more question for Jody, which is, any differences people might be expecting here? I mean, we've got natural history studies, we've got treatment trials. Is there a difference in the involvement that somebody might need to commit to between those different types of studies?
Yes. When you're doing a natural history study, your visits are probably less. When you're doing drug therapy, you will be seen more on site and more closely monitored. There's also a little bit more of EKGs and blood samples for a therapeutic study. You also will have a little bit of things outside of the clinic, as in recording stuff in a diary for the study team. Whereas a natural history study, you just come in, we do our assessments, and there's just like one blood draw. In a therapeutic study, it could be a couple blood draws throughout the day.
A question that sometimes I get, another question here that I sometimes get asked is, well, what's the difference between a clinic? Can we come see you in clinic and do the research? And the short answer there is that we do try and coordinate your clinical visit with your research visit. Sometimes I can do the entire clinic visit during your research visit, just to make, our job is to make your life simpler and less burdensome. And so that's an important thing. But if you have any questions or concerns, I would say to start with Jody or Kazi, who's the other coordinator in DM, and we can start to kind of facilitate and arrange, set the schedule appropriately. Oftentimes, frankly, during a research study, you're seeing our physical therapist, you'll see our speech therapist, you get a lot of the same team members that you would if you were in clinic as well. Just they're doing a different task there. So.
And might I add that, when you come to a research visit, we also are able to give you copies of EKGs or DEXA scans, things like that, that will save you probably some extra money, for to take back to your PCP things. So it's a little bit of a help and convenience for you as well.
The next question is for Jessica. So we sometimes, these new clinical trials that are coming now and we're going to expect to see coming in the near future, some of those trials have a placebo component to them. Sometimes I get asked a question, does it mean I'm not going to get the drug at all? Do you have any thoughts or guidance for people who are wondering hoping they're not going to get the placebo?
Well, that's definitely one of the, the struggles of research. Someone has to get the control so that we have something to compare to. And it is completely random and we have no control over that. We don't know who does or does not get the active drug typically, but it is a very important component of all of those trials. And often though, there are extension studies and open label studies where you might be in one or the other, but then eventually you would make it into that extension trial and get the actual drug. So just know that no matter which group you're in, you are still playing an incredibly important role in the research.
Yeah, I would add that many of these programs are designed to have an open label extension if it does not have safety signals or other issues. And so there is often an opportunity to receive the therapy once you get past that initial part, no matter what. So, so that's kind of the carrot at the end of the study. Jody, I noticed on that Marina site, is it true there's 44 patients total across all of the sites?
Across all of the sites, but they're broken up into part A will only have, I think 6 8 participants the first time because it's a phase 1. And then part B will have about 12, and then they titrate it down, and then the other 12, and then the other 12. So it's kind of a tiered process that'll get you to the 44 subjects.
That's not a lot of people
No.
that are participating. I myself am pretty excited about that one because this is an siRNA therapy that can knock down the DMPK transcript and potentially change the course of the disease should it prove to be effective. And so I think, I'm a little competitive myself, and I want to make sure that that you all as our patients here at BCU and the Children's Hospital have access to that therapy. So we'll be reaching out to you to try and get you in so we can make sure we have appropriate number of slots. So, all right, I think give people one more second. I think I've gotten through all of the Q&A, but maybe if I'll give you a second to, if you have any last minute questions, work our way through that. Since I don't see any, I am going to, oh, no, I lied. Oh, it's a thank you. Well, thank you. Thanks for attending. So I'll use that as my transition. So thank you. I want to make sure that many of you have time to get to the rest of your evening events. And so the first thing I want to do is to thank Melissa and Jody and Jessica, as well as the Children's Hospital Foundation for helping us host this first virtual open house on the first annual International Myotonic Dystrophy Awareness Day. I mean, I think, this is a day to really reflect on the condition, to reflect on the seriousness of it. I hope that we use this day as a mark to see how far our progress can come over the course of a year. And as I said, I hope by our second International Myotonic Dystrophy Awareness Day, we'll be talking a lot more about these new therapies that are coming down the road. So in addition to grant and institutional funding, our work is fueled by philanthropy. So we are lucky to partner with the Children's Hospital Foundation to raise critical dollars dedicated to research and improved outcomes and awareness of myotonic dystrophy. If you would like to learn more about ways you can become involved in these efforts or learn more about our program or clinic, you can visit the website here. I think all of you also have my email. So again, if you don't hesitate to reach out either to Carrie Bickford, they're happy to have you reach out directly to me by email as well. And then as a final reminder, this webinar is being recorded and will be shared with you in the coming days. And thank you again to everyone who joined today. And again, a special day here with the International Myotonic Dystrophy Awareness Day. And I hope that you can see here at the Children's Hospital of Richmond and BCU Health that we're dedicated to the condition and working very hard to solve it on your behalf. Thank you and have a great evening.